Hi, folks. Dan Sessler here. I'm chair of the Department of Outcomes Research at the Cleveland Clinic. Typically, we run 100 or more studies at any given time. What keeps me up at night is not the results of the studies. It's how those results might be wrong. And that's what I want to talk about today. There is no perfect study. All studies have built-in limitations. We're limited by practical and ethical considerations. You can't control all confounding factors, even in a trial, much less a retrospective analysis. And consequently, many studies attacking a problem from different angles are necessary to conclusively prove a hypothesis. But that said, good design limits the risk of false results. Statistics only partially compensate. Statistics make an effort to compensate for confounding, for example, but they only work for confounding that you know about and can accurately measure. Same thing for bias. Good design eliminates many sources of error. The major sources of error that we worry about are selection and measurement bias, confounding, and chance. The basic problem is that there are many causes of statistical association. What I mean by that is a p-value less than 0.05. So you get a p-value less than 0.05, temptation is to look at it and say, okay, these results are true. The trouble is that they may or may not be, and they may or may not mean what you think they mean. What you want when you say that p less than 0.05 for a given exposure and outcome is a causal relationship. That is, the exposure causes the outcome. But that's not always true. You may have a relationship that is truly there, but it's prognostic, not causal. That it's actually caused by something else, but your exposure is linked to something that causes the outcome. That's useful information, but it's very different from a causal relationship because you can intervene on a causal relationship. Intervening on a prognostic relationship will not improve the outcome. Then you have all these red dots, which are different sources of error. So these are situations in which you get a statistically significant result that's not actually true. Well, one that everybody appreciates is chance. This is statistics, this is random motion. And that's what statistics are very good at detecting. Statistics reliably tell you that the chance of a result is likely to have occurred by random motion or is unlikely to have occurred by random motion. So statistics is very good at that. Statistics have limited ability, though, to detect selection bias, confounding, and measurement bias. So that's mostly what I want to talk about now. Selection bias occurs when you have non-random selection for inclusion and treatment. And it has to be non-random to be a bias. So let's say you're doing a retrospective analysis, you're looking for people who have a particular disease. Okay, but subtle form of the diseases might be missed, but people actually do have the disease and that affects the outcome. Furthermore, treatments in a retrospective study may be non-randomly allocated. For example, newer treatments may be assigned to patients that clinicians think are most likely to benefit, or patients may self-select for one treatment or another, and nice patients read socially well-connected and rich may demand the latest and presumably best treatment. Compliance may vary by treatment. So patients may be allocated to a treatment or may select a treatment, but then drop out because they perceive it to be ineffective or because of side effects. Selection bias is largely prevented by randomization. Attrition bias, which is actually a type of measurement bias, is not prevented by randomization, but conventional selection bias is, and that's why so many randomized trials are done, and that's why randomized trials are considered the highest level of evidence. Measurement bias occurs on the other end. So measurement bias refers to how you evaluate the outcome rather than who is selected to be in the study, which is selection bias. The quality of measurements can vary non-randomly. And once again, it has to be non-random. Random error is not a bias. It degrades studies, but it's not bias. In retrospective studies, the quality of records is generally poor. Now, if it's poor randomly, it's not bias, but it's not necessarily randomly poor. For example, patients given a novel treatment may be watched more closely because people are interested in the outcome or they're worried about complications. Subjects with disease may better remember exposure. This is very common in cancer studies. You ask people with cancer what they've been exposed to, and then you get a 20-page data dump of everything they've ever been exposed to because they're obsessing about all the things that might have caused their cancer. You ask somebody who doesn't have cancer about exposures, and they say, not much, I'm exposed to ice cream. So you have a bias here because what they remember and report to you depends on their disease, non-randomly. Benefits may be overestimated, complications may be underestimated for treatments that are considered favored. And this is largely prevented by blinding. Blinding prevents most causes of measurement bias. So let me give you an example of measurement bias. This is a true published study. The investigators wanted to know whether arthritis is hereditary. So they did a very simple study. They found people who had arthritis in a very well-matched control group that did not have arthritis. So it's a case control design here. And they asked people whether one parent or both parents had arthritis. And the results were absolutely clear. The patients with arthritis were far more likely to report that one parent or both parents had arthritis. The p-value was 0.003, highly statistically significant result. There was just one problem, which is that the people with arthritis and the control subjects without arthritis were siblings. They had exactly the same parents. So what's going on here? Were they lying? No, they weren't lying. This is an example of measurement bias. The people who had arthritis were more likely to have talked to their parents about arthritis, and they were more likely to remember what their parents said. This study could have been done with controls that were unrelated to the arthritis patients. And had it been done that way, the investigators would have had no idea that measurement bias had completely made their results erroneous. Let me give you another example. So this was a study that compared no treatment and placebo treatment for pain syndrome, and they measured global improvement. Well, everybody knows about the placebo effect. So it's not surprising that people given a placebo rather than given nothing reported better improvement. And again, the result was highly, highly statistically significant. What's interesting about this study, though, is that the participants were told that they were getting a placebo. So they were given a placebo and they were told, this is a placebo. This is not a medically active substance. And they still got better. Never underestimate the placebo effect. And that's why blinding is so important. Measurement and selection bias show up differently for case control and for cohort studies. In cohort studies on the right here, investigators first identify exposed and unexposed groups, and then they look forward and they see who develops the disease or the outcome. Now, they can look forward in real time, it can be a prospective study, or they can look forward within a registry or a database. But the general structure of a cohort study is to first identify exposure and then look forward to whether people develop a disease. In that kind of study, selection bias shows up in the selection of the exposed and unexposed groups, and the measurement bias shows up in characterizing the disease later. In a case control study, you basically go in the other direction. Case control studies, you start by identifying cases, that is, people who have the disease or outcome of interest, and a matching control group, and you look backwards in time to see what exposure they got. Case control studies are always retrospective. Cohort studies can be prospective or retrospective, and in fact, a randomized blinded trial is a type of cohort study. In a case control study, selection bias shows up in selection of the cases and controls, and measurement bias shows up in how you define the exposure. Confounding is the other thing that we need to worry about. Confounding is not a bias, but it definitely produces erroneous results. Confounding is an association between two factors that's caused by a third factor. To take a trivial example, mortality is greater in Florida than Alaska. It really is. People in Florida are far more likely to die than people in Alaska. But it's not because Florida is a dangerous place. It's because the average age is much higher in Florida. And if you adjust for age, then the difference in geography, the Florida versus Alaska, goes away. The age-adjusted mortality is actually nearly the same in both places. But if you don't know that age is a confounding factor and you don't adjust for it, you will get completely the wrong answer and conclude that Florida is a more dangerous place to live. To take a more medical example, transfusions are associated with mortality. But patients who have larger, longer operations lose more blood, and therefore they require more blood. They're given more transfusion. So if you just look at the relationship between transfusions and mortality after surgery, you will find that there's a very strong, highly statistically significant relationship. But it's not primarily driven by the transfusions. It's primarily driven by the fact that patients who are sicker and having larger operations require more blood than patients having smaller operations. If you adjust for baseline illness and the type of operation, the effect of transfusion is either small or non-existent. To give you another non-medical example, there's an association between ice cream consumption and shark attacks. Well, it's because people eat a lot of ice cream in the summer, and they also go swimming in the summer and are more likely to be attacked by sharks. So it's just confounding. Ice cream, of course, has nothing to do with shark attacks. Confounding, like selection bias, is largely prevented by randomization. And that's why randomized trials are considered the gold standard. Now, there's one subtlety here, which is that a confounder, by definition, is linked to both exposure and outcome. If it's not linked to both of them, it is not a confounder. A mediator is different. A mediator is how an exposure causes an outcome. So if you give people a transfusion, maybe the transfusion generates an inflammatory reaction and that worsens outcome. In that case, transfusion is a or inflammation is the mediator between transfusion and illness or bad outcomes. Now, it might seem obvious that confounders and mediators are separate. The trouble is, in real life, it's often not at all obvious. And you have situations where you're looking, say, at the effects of anemia on outcome. Well, anemia causes transfusions. People who are anemic are more likely to get a transfusion. So anemia causes transfusions, which might worsen outcomes. But anemia also makes it more likely that people will get a transfusion. And sometimes these are all happening at the same time. So these complicated relationships between intraoperative bleeding, confounding, and mediators. So you have anemia, then you have blood loss during surgery, then you have low hemoglobin, then people are given a transfusion. And this is all happening at the same time. And it's not always obvious what's a confounder and what's a mediator. The distinction matters because it's important to adjust for confounders. If you don't statistically adjust for a confounder, you will identify a true relationship that is not actually there. It's actually a confounded relationship. It's not a direct relationship between exposure and outcome that you think you're measuring. If, on the other hand, you adjust for a mediator, you make true effects go away. So it's important to figure out which and which. Now, this is a subtlety, but it gives you an idea of some of the sources of error and how difficult it can be to adjust for them in various studies. So to summarize here, you have internal validity and external validity. Internal validity is how reliable the study is, in the sense that if you exactly repeated that study, are you going to get the same answer? And that depends on control of measurement bias, confounding, chance, and how well you actually do the study. But then you have external validity as well, which is also referred to as generalizability. So you could do a study with very high internal validity. So if you exactly repeat the study, you'll get the same answer, but it might not apply to patients other than the ones who were in the study. Technically, the results, even of a randomized blinded trial, apply to the patients who were in the study. Now, most people will say it probably applies to people who would have qualified to be in the study. But the difficulty is that the patient you take care of tomorrow has not been in the study and probably doesn't actually qualify for the relevant study. So you need to decide whether you're going to extrapolate from available, often tightly controlled results in specific populations to the patient in front of you. There's no fixed answer here. This is clearly where clinical judgment comes in, because you have to decide how closely your patient resembles the ones who are in the studies. Now, personally, I tend to extrapolate pretty far because the alternative to extrapolation is clinical judgment, often referred to as making it up. But more seriously, you need to decide whether the results are likely to apply to your patient or unlikely to apply for your patient, and then make some reasonable clinical decision. And that's it. Thank you much.